Right, so welcome everybody. I have a long list of instructions from Alicia, so I'll make sure I do all of these things. Welcome to the DMD update session. My name is Christy Jones. I've been around a while at MD-NSW and been to an awful lot of these sessions over the years. And so I think it's amazing that this can run so easily and so cleverly by remote. So this session will go for about 40 minutes. Now, Michelle Lorentzos, who wasn't on the program because I didn't get my head around it until recently, is going to run this session together with me. Michelle is a pediatric neurologist at the Children's Hospital. Her area of interest and main role is in clinical trials, particularly in Duchenne Muscular Dystrophy. And we're going to run a session that we'd like to be as organic and relaxed as possible. So we're really happy to deal with as many questions as come up, and if we do have some content, but if we don't get through the content because we're answering questions, then we're really fine with that, because we want to make sure people get a chance to ask what they'd like to know. So I'm going to hand over now. So the only other thing I had to say on my list was that if you want to join a different breakout, you can leave, go back to the main session and be reallocated. The questions are working really well via the chat, so that would be great. And if you get stuck, go back and talk to one of the Alicias in the main session room. So I'll hand over to Michelle and we'll get going.
Thank you for the introduction, Christy. Now let's try and share my screen here.
I'm supposed to make you...
Does that work?
Yep, that's good.
Can you see that?
Yep.
Somehow my okay. Oh, hang on a second. Let me just sorry, wrong slides. Let me just open the right ones. There we are. Okay. Okay, so thank you very much for the introduction, Christy. So yes, I'm a neurologist at the Children's Hospital at Westmead. Now, we have had a bit of a busy presentation week because we had an information forum for our patients on Wednesday evening. And so Christy and I were very conscious of not wanting to simply replicate that presentation and assuming that there might be some of you that were there for that as well as there for this. And we also wanted to keep this as a casual Saturday afternoon chat, really, where people could submit questions and we'd answer them organically. Now, I don't think Christy would mind me saying that she's as talkative as me. So we're both quite good at chatting, but what we really want to refer back to the questions that you're asking. So please feel free to submit questions on the chat. Christy, I can't see the chat. Can you see it?
Yes, I can see the chat.
Okay, so we'll try as much as possible to really take this discussion to where you would like it to go. So what we're going to talk about today is the changing landscape of treatment in DMD. And we thought that the best way to do that in a discussion way was to have some patient examples or little vignettes that would prompt further discussion. So with that in mind, the aim is going to be to present practical patient-based questions that will allow us to discuss some new and emerging therapies in Duchenne muscular dystrophy. So just before just some fundamental concepts, some of this has already been covered today, and so I'll go through it briefly, and I'm sure most of it's familiar to you all anyway. But obviously, Duchenne muscular dystrophy is a genetic condition that occurs because of a mutation or a mistake, if you like, on the X chromosome. Now, the X chromosome is made up of 79 exons, so it's a fairly big gene as far as the human body is concerned. And so the mutation or mistake, if you like, can occur in one or several of these exons. Now, in its most simplest form, the way we think of DMD is that it's an inability to make something called dystrophin, which is a really important protein for the structure of muscles. And so over time, that leads to progressive muscle weakness and fibrosis. So you can see on the left, we have a picture of healthy muscle, and on the right, a picture of muscle in Duchenne muscular dystrophy. So we have weakness and fibrosis occurring. And fibrosis is essentially a medical word that means scarring and injury. So the current treatments in DMD, now most of you would know this well, and we won't kind of go over this too much, but obviously there's education and counselling that occurs at time of diagnosis and following on from that ideally, targeted physiotherapy and OT interventions, learning and behaviour interventions, supportive care, so surveillance and management of complications that occur, including cardiac, respiratory, musculoskeletal, amongst others. as well as an evidence-based steroid regimen. So we know that administration of steroids is the most effective treatment we have so far at delaying worsening of the condition in DMD. And of course, access to peer and community support, of which today is an excellent example. Apologies, but you have some talkative budgies also contributing to the presentation in the background, if you can hear that. So how can drugs impact the DMD process? So from the mistake or mutation in the DMD gene, and we think of genes in the body as being like recipes or instructions. So they basically tell the cells in the body how to make what they need to make and do what they need to do. So that mistake therefore leads to a problem with making dystrophin. And then that lack of dystrophin, as I said earlier, leads to muscle injury and scarring. And so in terms of what drugs can actually do, they can either, interact where there is a mutation itself, so gene replacement therapy interacts at that step. They can intervene at the point where in terms of the reading of the mistake, so where the cells read the mistake in the gene, so things like exon skipping intervenes there. Or they can actually interfere with the muscle injury itself. So that's where steroids actually have their role, not so much in the problem with the gene or the reading of the gene, but in terms of the muscle injury. Now, for some reason, it's not letting me skip forward. Let's see if this works. Oh, so there we go. So the gene replacement therapy at the reading level or at the muscle point itself. Okay, so now in terms of the things that we thought we'd use as like springboards for discussion. So I'll start with patient one, unless, Christy, there's any questions so far that we need to address?
No.
Okay, all right, I'll carry on then. So patient one, my 5-year-old son has Duchenne. So he's been taking daily prednisolone now for 1 year. Recently started kindergarten, and I have noticed that his behaviour seems to be worsening. He's becoming more of a handful at home, as well as I'm not sure if he's necessarily behaving on par with his peers at school. Could this be the prednisolone? Should we stop it? If we stop it, what else can we do? So we thought we might have a bit of a discussion then about, behaviour, prednisolone, and also those alternatives. So I guess the first thing to suggest, and I'll also go to Christy to talk about this, is that this is a question that comes up very commonly for us in our clinics. And we know that interpretation of behaviour in a child is a complex thing, and it's often hard to put it down to one simple reason. So, Christy, did you want to try to talk about this, and then we can go back and forth, I suppose?
Well, I think the first thing is that we shouldn't chop and change too much. Often, obviously there are many, many things that go on in a child's life or a teenager's life. And just because they're on prednisolone doesn't mean that's the only cause of the problems they might be having. And so most of the time, if you write it out, you don't actually need to change. That said, many people like to be on deflazacort, although, what you might gain with one of those steroids, deflazacort versus prednisolone, you might lose with the others. So some people do better on prednisolone, some do better on deflazacort. In Australia, we have to start on prednisolone, and then if you fail, in inverted commas, prednisolone, we can apply and change to deflazacort. But we have boys on both. So I think the first thing is sit it out a bit, see what happens. We can alter the regimens. And I think, Michelle, you were going to come back and talk a little bit about different steroid regimens, because there are many different types of steroid dosing schedules that I've used in my 20 years in this area. And I think we sort of come back to the tried and true, but it's worth thinking about those options. I think also we accept a lower dose of steroids for individuals than I might have in the past. I used to fairly religiously stick to the 0.75 milligrams per kilogram, increase it. Whereas now, if the boy's doing well and not having too much in the way of side effects, or side effects are sort of under control, but we want to keep an eye on that, we'll tend to sit on it. And it's interesting, most clinical trials that require boys to be on steroids require them to have a stable dose of steroids for a period of time. But recently, excuse me for a minute, guys, I'm talking. Sorry, I have a bunch of teenagers in the background. Where was I saying? I got distracted.
Lower doses of steroids.
Yes, that's right. I think, it's interesting. One of the trials that we've just been looking at, boys have to be on a minimum of 0.3 milligrams per kilogram, which suggests to me that a lot of boys around the world are actually settling for a lower dose and still getting quite good benefit, which I think is quite interesting. And then I know Monique mentioned earlier vamorolone. So, obviously side effects of steroids are the bane of our lives. We end up chasing side effects all of the time, even though they have made an extraordinary difference to the lives of boys with Duchenne. I remember scoliosis surgery used to be a major event in the vast majority of boys' lives. And I can't remember the last time we did scoliosis surgery for Duchenne for a boy on steroids, because they're all on steroids and you don't get that type of scoliosis. So it's fairly extraordinary. Anyway, I'll hand over to Michelle, because I think you were going to.
Yeah, so just to add on from that, so I think echoing what Christy said, that behavior is very multifactorial in children, as you all know, and in fact it's not unusual for a lot of kids to have alterations in behavior when they first start school, simply because of overtiredness, change of routine. And so we do like to make sure that we give things a good run, because it is difficult if we keep making changes to medications to then monitor what's causing what. I think the other thing just to mention at this point, as many of you would be familiar with, but in case you're not, that the reason that we give steroids and tolerate these side effects is because they do have a number of benefits. So in terms of both prolonging life expectancy, cardiac health, respiratory health, and also prolonging period of ambulation, as well as upper limb strength. So for all those reasons, we do think that they're very beneficial despite the side effects. The other thing to say is that it's not a one-way street. So in patients that I've looked after where we have decided, okay, well, let's change the dose, or let's think about changing the steroid regimen, or even stopping them, it is always good to know that you haven't closed the door, because you can revisit that. And I'll wait to actually go to my next slide to talk. Okay, so current medication. So obviously we use high dose steroids to delay in delaying loss of ambulation. Then what weekend steroids are something that we're using a little bit more at our centre, in terms of not just for administering daily steroids, but there have been studies done states that have demonstrated that by using steroids on the weekend only and giving a much higher dose, that you can actually achieve the same results and decrease side effects as you would by giving a smaller dose every day. So basically these boys have no steroids Monday to Friday, and then higher doses on Saturdays, Sundays. We have a few boys on that regimen. And alternate steroids, I have to say we don't use very frequently, but that is another regimen as well. So
people have trouble remembering when to take them and when not, in my experience.
Yes, exactly. So often, even if you do alternate day steroid, what that actually tends to mean is you pick a couple of days, like Monday, Wednesday, Friday, where you give them, and rather than having to keep it, just there happens to be an odd number of days in a week, and they can get quite confusing. So the other thing, as Dr. Monique Ryan spoke about in one of the answers to the questions when we talked about alternative to steroids, is that there is a synthetic steroid that has been developed called vamorolone, which essentially interacts with some of the receptors that steroids traditionally react with, without activating the receptors that cause the side effects. So the idea is all the benefit without the cost, if you like. So small trials have shown that there is safety and efficacy with vamorolone, and the larger trials are ongoing. So we've participated in a vamorolone trial where recruitment is now finished, and we're waiting for the results of that to come. But what we're expecting to find, it's probably not a lot better than traditional steroids in terms of its benefit, but probably about the same, with significantly less side effects. So that in itself is a benefit. The other thing is that in this area of research, the other things that can interact at the point of the muscle are drugs that actually can prevent fibrosis. And there is a drug developed by Fibrogen, which is currently underway in phase 3 clinical trials, both in non-ambulatory and ambulatory patients. And the hope is that this can prevent fibrosis in patients with DMD. So the next patient is a 10-year-old boy with DMD, and the cardiologist has suggested starting an ACE inhibitor as a medicine for his heart. So far, all his heart surveillance has been normal. And so the question is, he's already on steroids, and I'm concerned about adding yet another medication if this is not necessary. So should I give him the ACE inhibitor? So Christy, do you want to answer this one?
And it was obviously great hearing a lot of information about these drugs from Dr. Tanis. But I think this is one of the biggest changes that we've had in our clinic in terms of general management and thinking about this. So we know that the heart in Duchenne and Becker, for that matter, is actually not normal from the get-go. And traditionally, we wait until the ultrasound, the echo, can pick up signs of the heart not coping quite so well before we treat. But that's not particularly logical if you think about it, because, you know, now if we use more intensive investigations such as the cardiac MRI, we see changes much, much earlier. And if we did a muscle biopsy of the heart, you'd see changes from the beginning. So the question is, maybe if you start to give some medications that reduce the stress on the heart, reduce the heart rate, or reduce the pressure that the heart has to pump against, maybe you can reduce the chance of the heart actually developing problems, or at least slow things down. And we're pretty cautious in giving boys with Duchenne medications for no good reason. And the studies are fairly preliminary, but there's certainly some early data that suggests that early use of things like ACE inhibitors, which are drugs that reduce the strain that the heart has to pump against, can result in improved heart function over time. And ACE inhibitors are very, very well-known drugs. So in terms of side effect profiles and tolerability, it's not a huge risk. So, you know, I think all the centres approach this a little bit differently, but I know our cardiologists usually watch kids till they're about 10, and then they start the discussion about, okay, well, your heart looks normal on ultrasound, but maybe it's time to think about putting in a preventative medicine. And I think that makes a lot of sense. So my suggestion is that people raise this conversation with their cardiologist, because all of them will feel a little different and all the boys will be in a slightly different place. But I think it's a really big step forward.
And Christy, just I have worked out how to see the chat now, so I can see a couple of questions. One of them is, can we talk about the pros and cons of pred and deflazacort? So I would say that the main advantages deflazacort tends to have over prednisolone is that it does tend to be, the boys generally tend to gain less weight than on prednisolone. And I think some families find that the behaviour profile is better to deflazacort, but I don't know if that's the case with all children. Anything else to add on that, Christy?
No, I don't think so.
Yeah,
I think we used to focus much more on the differences. There's probably more cataracts with deflazacort, but weight gain in reality is one of the biggest problems, and I don't find one particularly better than the other. I think more people are on deflazacort in our cohort, and I think the fact that PTC spent a very large amount on buying the drug suggests that their data from that they've collected suggests that they think it's better. We have boys on both, and some do very well on prednisolone, so I don't feel strongly.
and the question about once vamorolone is approved, will the boys be able to switch over? But yes,
I think the $1 million question is how much they charge for it, really. So, you know, in Australia, we don't, I mean, I don't actually know how much we pay for deflazacort, but prednisolone's cheap as chips. Thinking, as Monique said earlier, Emflaza, as they call deflazacort in the States, is actually quite expensive now. And if vamorolone is hugely expensive, I think that will be the issue. I mean, we will obviously...
Have any idea how much they're going to charge for it?
No, I've got no idea, Monique. Thank you for piping up. No idea.
It'll be a lot, though. I mean, it's been in development for a long time.
Yeah. I mean, it is an interesting development model, the vamorolone model, because it was through the university, wasn't it? It's not a typical pharma development. There's still got a lot of costs.
Yes, exactly right. Yeah, that's why it went to Synergy first, because it was developed through the Washington system.
Yeah. I think if vamorolone, if the results of efficacy were dramatically better, that might be different. And obviously it's good that it's got lower side effects, but I have to confess to being a little disappointed that it didn't have better efficacy. It didn't do better compared to prednisolone and deflazacort.
I think one of the spaces where it might be interesting is to see how it goes in even younger boys, because I think we would potentially start steroids even earlier if they didn't have side effects. So,
well, I think that's very true. And, you know, we do have boys in our cohort that were diagnosed under the age of 2 and started steroids then. And whilst they're rather short and weight is a problem, they're doing very well from a muscle point of view.
So which kind of answers the next question in the chat to some extent, where Dave asks, are the normal treatments now starting at an earlier age? And I think there is evidence to suggest that the earlier we can treat, the better we think preservation of strength will be. But we are somewhat hamstrung by the side effects of these drugs and the lack of evidence about. So, for example, if you start steroids at 6 months of age, what would the bone health of that boy be at 12 years of age? And so, the more we can have therapies that have benefit with less side effects, the better we are in terms of treatment.
There was a big push from one of the UK centres a few years back to start the steroids from 2 years of age, and there were some papers around it. But again, I don't know that it really took off because of side effects.
And absolutely, in the weekend-only steroids, one of the utilities of that has been the centres in the centre in America where they have been dosing boys as young as 4 months on weekend-only steroids. So just moving on, I'm just conscious of time, but feel free to continue sending your questions through if you have any. So the other thing that this mother or father was asking is that it's a nonsense mutation. What can you tell me about adalurin, which I've heard about? So, this was the ACE inhibitor slide, which we've now covered preemptively, but we know that, so Christy is already going to give us...
I think move on, Michelle. Yeah, I don't...
So there are different types of deletions in DMD, and the one of the
types of variants,
adalurin. Sorry, different types of variants, not deletion. Sorry, this is what happens when I'm trying to rush. Types of variants, one of which is called a nonsense mutation, which is basically when there's like a full stop that's put into the gene, which causes it to stop and not continue with the rest of the instructions. So adalurin works only on those types of mutations. So adalurin is otherwise known as Translarna, and it's thought to be effective, hopefully, in that group of patients only. So about 10 to 15% of patients with DMD. And what it really does is allows the reading material to skip over that or continue through the full stop, to ignore the full stop is there in essence. And there have been smaller studies that suggest that adalurin is effective in delaying loss of ambulation. It's generally pretty well tolerated, but there are most of the side effects tend to be gastrointestinal. And it is actually approved in the European Medicines Agency, so not approved by the TGA or FDA. However,
I think having had boys on adalurin now for more than 10 years, it is the easiest drug to take. Would you agree, Monique?
It's incredible, and no one's ever had a side effect. It's extraordinary.
No, we're the same. We've done trials on this for more than 10 years. It's easy to take. It's very well tolerated, and I agree with Monique. I agree with you, Monique. I think it works, and I'm gobsmacked that the US is approving some of these exon skipping drugs with very dubious data, and yet the poor adalurin people can't get their drug over the finish line. When actually the boys of ours that have been on this for the last 10 years are doing really well. In terms of boys well into their 20s not needing respiratory support. Anyway, that's the vagaries of drug approval.
So our third scenario is a parent asking that now that their son is non-ambulant, is there any benefit to continuing steroids? So Christy, did you want to?
Deb, your question is perfectly timed. Do you believe the continuation of steroids post-ambulation is still valuable? The short answer is yes. Obviously it depends on side effect profiles and an individual, but there are benefits in terms of cardiac outcomes, there are benefits in terms of respiratory outcomes, there are benefits in terms of scoliosis and in terms of upper limb strength. So this is where I think, not pushing the dose to the top, finding a dose where you get some benefit without, with a tolerable level of side effects. The other thing that is important is that many of the clinical trials still require boys to be on steroids and on a stable dose of steroids. That may or may not be relevant, but I don't get upset if someone wants to stop, but I do suggest that they really think long and hard about it. It also isn't easy to stop and start. So it's not like some medications where you can say, look, I want to stop it and then I'll restart. Coming off steroids, because of the fact it dampens your adrenal glands, so your steroid responses, it's not an easy thing to do. So you've really got to it's a big decision to come off steroids because it's not easy to, I think they taper them down over quite a long time.
Yeah, and sorry, I was just going to add, Christy, I think as well that, so often in talks and in studies we focus on ambulation, but the more boys I see with DMD, the more, we recognise, I recognise, I should say, how important that upper limb strength is. And so in terms of independence and quality of life, and so preserving that as a really important factor can be important. But I think we do take it on a case by case. If there are effects that are making that boy's life, or young man's life, I should say, miserable, then absolutely it's worth discussing it with your clinician and discussing, are there, modifications you can make to address those side effects?
I think one thing that I would say, though, is that some boys get to this age and they hate being short. And unfortunately, whilst steroids is an influence on making you short, stopping steroids when you're a teenager is not going to make you tall. And that's a really hard thing to talk about to teenage boys who don't want to be short. But it's not a really good reason to stop steroids. It will make you less round and help you lose weight, but it's not going to make you tall, unfortunately.
So are there any new therapies or clinical trials for which you might be eligible? So we do know, and it is it's made publicly available, that there are clinical trials in gene therapy that are being developed for the non-ambulant cohort. So our spaces for those trials may be somewhat limited, and they may not be in all centres around Australia, but we know that that's a potential pathway in terms of clinical trials.
Sorry, Michelle, I just got distracted by a question. Kevin, there is no such thing as a super ignorant question. Of course, you can ask it whatever it is. Sorry, what did you say, Michelle?
No, I was just saying that we know that there are gene therapy clinical trials that are being done for the non-ambulant group.
I think there was, in the early days of clinical trials in Duchenne, they were all in the 4 to 7 year olds. So there was this sort of precipice. After 7, there was just nothing around. And one of the reasons for that was that a lot of the trials were focused around the outcome measure of the 6-minute walk distance. And when you design a trial purely around an outcome measure, then you're really stuck with that age group. But luckily, and well, not luckily, I think it's great to see that there are a lot of trials now in coming into this group of non-ambulant boys, looking at heart function, lung function, and upper limb function. There are gene therapy trials in this age group, and hopefully there will also be anti-inflammatory drugs in these groups coming through. Yeah.
Excellent. So just just in terms of an explanation for some of that. So gene replacement therapy is something that's been much anticipated, and we've seen successes in other diseases like spinal muscular atrophy, where Zolgensma, a gene therapy product, is leading to fairly transformative changes in patients, essentially preventing them from developing the symptoms if they're treated early enough. But it's early days in SMA, and it's quite a different disease to Duchenne. So whilst we can be optimistic, we try not to be unrealistically optimistic about its translation into DMD. But just in terms of how it works, basically gene replacement therapy is where you get so recognizing that there's a faulty copy of the gene in the patient, you get a new gene that is not faulty. And in this situation, it's a smaller version of the DMD gene, because the actual version would be too big. And it really hitches a ride on a virus. So we call that the virus the vector, which is like the transport, if you like. So it hitches a ride on something called adenovirus, gets put into the patient, and the virus then gets taken into the cell carrying the new gene to then become part of the patient's genetic makeup. And the hope is that this will create a significantly less phenotype. In other words, a much less severe form of muscular dystrophy for these patients.
I think what's really interesting, and I had to look this up recently for a committee that I had to answer to about gene therapy. So we say that the definition of Duchenne is having just a few % of the usual amounts of dystrophin floating around, and that you actually only need a few % more to make a big difference to the ability to walk. So you don't need 50% of the normal dystrophin or 75% of the normal dystrophin, but 10% of normal dystrophin actually would make an enormous difference. And that was something that I really hadn't realized. Even if you've got 6 or 7% of normal dystrophin, we really could expect that might make quite a difference. I think that's really interesting.
So we know with gene therapy, whilst that there is hope and quite a lot of focus both from industry as well as in the medical field on gene therapy, that the early evidence definitely shows that there is a biochemical difference. So the boys in the very small trials that have been done have been shown to produce have been successfully in producing mini dystrophin or microdystrophin. However, in terms of how it's affected their function is a bit difficult to interpret because of the small size of these studies. There have been some serious adverse events reported in patients. All of them were resolved, but quite a large portion, so about a third of patients treated in one of the studies of only 9 boys, so 3 out of 9, had fairly serious side effects, although they did actually resolve. And so the damages can be in the liver, immune responses, kidney damage. And the other thing about gene therapy is once you've changed someone's genetic profile, you can't really unchange it. And we think you can only give it once. So if you've been in one gene therapy trial, it's very unlikely you'll be eligible for gene therapy trial later on.
I'm not sure we know that for sure yet, but people aren't keen to rush in and give people a second dose at the moment. We don't really know long term what will happen with people who had gene therapy very early in life. But it is something we can't presume that they can have it again.
And just this is our last little case, but we wanted to talk about another patient who has a deletion in exon 45 to 50, meaning that they are eligible for an exon 51 skipping medication in terms of the mutation actually being amenable to that. Are there any clinical trials, and would he be best to enroll in one of those exon skipping trials or wait for a gene therapy trial? So exon skipping only works for deletion, so which is actually the most common type of mutations we see in DMD. And again, only works in an exon skipping in a particular type of deletion, of which about 30% of boys with DMD are thought to have. So certainly not all deletions are amenable to exon skipping. And really the way in which exon skipping works is that if you were to say that a patient had a deletion out from these exons, so you've got 40, sorry, I think my little cursor's moved. So say 46 to 47 has been deleted. Then if you try and imagine that you need to create a bridge to make the recipe make sense, 48 can't join on to 45 because 48 has a straight edge and 45 has an arrow. But then if you were to actually skip over 45, like I've done here, then 48 can in fact join on to 44. And that's how they create somewhat of a bridge to make a smaller version of the DMD gene to make some dystrophin. So so it's those types of mutations only, or those types of deletions that exon skipping is effective for, or hopes to be effective for. And there are various tools online, like the Parent Project DMD tool that you can actually type in the deletion and see if it might be effective. So about 30% of patients are thought to have mutations amenable to the exon skipping agents that are currently around. All of these agents I've listed above are have a conditional FDA approval code, so can be prescribed in the States, but not here in Australia, and there are currently trials ongoing. They do have a bit of a burden of care, so they involve weekly infusions, and currently some second generation exon skipping drugs are being trialled where they're hoping to make them better targeted to the muscles, so you don't have some of the side effects that we currently see in those being trialled. But I guess the complicated question here is, if you had a son that was eligible for an exon skipping drug, would you put him in that trial or would you wait for gene therapy? Christy, any thoughts on that question?
I think it's a really, really tricky question, and one that I think a lot about. And I think it's a very individual discussion that people need to have with their own clinician. And if your clinician isn't someone that's actively involved in clinical trials, what we usually try and do is have a 3-way conversation. So maybe I might, for example, go in and join one of the other neurologists in our muscle clinic with the family to discuss these things, because you need to take in factors about the child or the teenager, as well as factors about what their treatment is, and then factors of the treatments that are around. What other things are available for them? How do you feel about the side effects? What does the young person think? Because this has significant implications for them as well. So I think the idea is to get into these questions and discussions early, so that you are realistic about your expectations and you have some time to think about the pros and cons of them. We are very circumspect. We never take the approach that we want to encourage people to be involved in these trials because it's a big step. But obviously we do them because we think it's important people have the opportunity to consider involvement if possible. And then, of course, the important thing to remember is this: as soon as a treatment is shown to work, it's reassuring. I mean, it takes a while, but actually the SMA experience tells us that, when you have a dramatically effective treatment, it's remarkably quick. Would you agree, Monique, to get into the everyday? Well, I always used to think drugs took a very long time to get into everyday life. But in fact, when they work dramatically, like in SMA, they've actually been remarkably quick.
Yeah, there's issues with getting Zolgensma approved.
Yeah.
Well, subsidized. Just because it's single dose and it's so extraordinarily expensive, they're actually having a lot of difficulty getting
So we're
it subsidized.
talking $2 million, aren't we, a dose?
Well, that's one of the questions, how much we are talking.
Yeah. But in terms of thinking about whether to be part of a clinical trial, it is really a three-way conversation between families and the boy, your clinician, and then hopefully having contact with someone. And I'm sure Monique's the same. We are always happy to join consultations with other people, other doctors and other clinicians, to bring our specific perspective on clinical trials.
So we've got another minute or so left. So there's one question here last question about avoiding the Pfizer vaccine.
I don't think we're the right people to ask, but the short answer is no.
Yeah, so they did discuss this in a recent gene therapy webinar that Christy and I attended, and they did say that really it shouldn't deter people from getting vaccinated because they're worried about gene therapy eligibility in terms of trials.
No, there was nothing mentioned about that I'm aware of. There are some vaccinations, live vaccinations, you can't have just before gene therapy. I think that's right from my memory. Yeah. But none of the COVID ones are live vaccines.
So I think really just in closing, I hope what we've tried to talk about today is the fact that, I think what we've demonstrated hopefully is that there often isn't a single answer to many of these questions, and they're quite complex, and that one of the most important factors is the open dialogue between you and your clinicians, and then if your clinicians aren't comfortable with the clinical trial landscape or aware of emerging therapies, that they can liaise with other clinicians that are. And there's a very collegial network of doctors and allied health who work in DMD from around the country that meet regularly and share information. So whilst what we really wanted to be able to have one of these sessions where we say there is a cure and it's widely available, and in the absence of that, I think we can be somewhat positive but realistic about the fact that there is considerable attention on treatment in DMD around the world, and that we are witnessing the benefits of advanced therapeutics in other diseases.
Okay, this room is going to close in 51 seconds. There are a couple of questions coming in, which I'll just answer on the chat. But thank you all. We've got 41 seconds. Someone's asked if a genetic test was done many years ago and it was not conclusive. Is it worth redoing? Definitely. We redo genetic tests every couple of years. And how would you do this? You would approach either your own doctor or your local genetic service. If you look on the genetic education website, there are links to your local genetic service, or you can talk to your neurologist or doctor where you are treated. Kevin's asking some questions about collagen 6. Treat NMD has really good information about clinical trials for all sorts of different things, and the PPMD, I think it is,